Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Ryan Topping. Today's episode features expert discussion of the most clinically relevant data in breast cancer presented at the 2025 ASCO Annual Meeting, including data from the DESTINY-Breast09, ASCENT-04, SERENA-6, and INAVO120 trials. This episode is part of a larger educational program titled CCO Independent Conference Highlights from the 2025 ASCO Annual Meeting. For more information on Dr. Kevin Kalinsky and Dr. Sara Tolaney, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about this important topic.
The first study that we're going to cover is DESTINY-Breast09. This is a trial that really looked to understand if T-DXd with or without pertuzumab could have a role for treatment of first-line metastatic HER2-positive breast cancer. We've known that T-DXd really has dramatically improved outcomes for patients with metastatic HER2-positive disease and is currently approved as a second-line standard of care based on DESTINY-Breast03, where we saw, I think, an unprecedented progression-free survival of around 29 months. But we've also known that the current first-line standard of care, taxane plus trastuzumab and pertuzumab, has a PFS of around 19 months. So there's a lot of interest to see if we could move T-DXd into the frontline setting. And so DESTINY-Breast09 was really designed to address that question and took patients who were previously untreated for metastatic HER2-positive disease and randomized them to get either T-DXd alone or T-DXd plus pertuzumab, or a taxane with choice of paclitaxel or docetaxel with trastuzumab and pertuzumab. And so for those patients who are randomized to the T-DXd containing arms, they were treated with T-DXd until disease progression. If T-DXd had to be discontinued early due to toxicity, then trastuzumab could be added, which was given alone in the T-DXd plus placebo arm or in combination with pertuzumab in the T-DXd plus pertuzumab arm. And for those patients on the THP arm, the taxane had to be administered for a minimum of 6 cycles or until development of toxicity, and then patients moved on to receive trastuzumab and pertuzumab. And for patients who had hormone receptor positive disease, endocrine therapy could be added, either after a minimum of 6 cycles of T-DXd or after taxane discontinuation. And the primary endpoint was progression-free survival, comparing T-DXd and pertuzumab to THP and comparing T-DXd and placebo to THP. But the two T-DXd containing arms were not powered to be compared with each other. And so at ASCO, what we saw were results from the interim analysis comparing T-DXd plus pertuzumab to THP. And this was because the T-DXd and pertuzumab arm reached superiority at the time of the interim analysis based on the very stringent criteria that were set for interim success. However, the T-DXd alone arm did not meet the criteria set for superiority at the time of the interim analysis. And so that arm remains blinded and those patients continue to be followed. And we won't see data from that arm until the final PFS analysis. Here you can see the results from the primary endpoint of progression-free survival, which showed that the combination of T-DXd and pertuzumab led to statistically significant and clinically meaningful improvement in progression-free survival, with a median PFS of 40.7 months for T-DXd and pertuzumab compared to 26.9 months for THP. This is consistent with a hazard ratio of 0.56 and a p-value that was less than 0.00001. So really, I think a very striking difference between the two arms. One thing I would point out is that when you look at the curves, you can see that they do separate very early. So when you look at the 6-month landmark analysis, you can see that at 6 months, about 12% of patients had already progressed on THP, whereas you see half as many patients had progressed on the T-DXd and pertuzumab arm. And over time, you see that the curves continue to widen and separate, but you do see that there is a lot of instability on the tail of the curve. And I would keep in mind that the median follow-up at this interim analysis was 29 months. So there are very few events at the tail of the curve, and that's what's leading to all this instability. And we do know that at this time, 46% of patients on the TDXD and pertuzumab arm are still on treatment. And so it does suggest that the median is likely to evolve with further follow. When you look at the other secondary efficacy endpoints, you can see that the objective response rate was numerically higher with TDXD and pertuzumab compared to THP, and the complete response rate was almost double at 15% with TDXD and pertuzumab compared to THP. Importantly, the responses were also substantially more durable with TDXD and pertuzumab, where you can see that the median duration of response was almost 40 months for TDXD and pertuzumab compared to about 26 months for THP. One thing to keep in mind is that overall survival data is still very immature. There are only 16% of survival events that had occurred at the time of the interim. There was a slight trend for survival benefit for TDXD and pertuzumab with a hazard ratio of 0.84. But because survival was so immature, we thought it was important to also look at PFS2, which is defined from the time of randomization to time of progression on second-line therapy, just to get a flavor for how patients are doing in terms of longer-term outcomes. And you can see that the hazard ratio for PFS2 was 0.6, again favoring a TDXD and pertuzumab. One of the questions that certainly arises when you look at PFS2 is what are the therapies that patients are receiving in that second-line setting? And so if you look at the patients, for example, in the control arm who had discontinued THP and then went on to receive a second line of treatment, 10% of patients received TDXD as their second line treatment, and 12% had received TDM1. When looking at the safety, you can see that overall the duration of therapy is substantially longer with TDXD and pertuzumab at about 22 months compared to about 6 months of cytotoxic therapy in the THP arm. But despite the very much longer duration of cytotoxic treatment with TDXD and pertuzumab, you can see that the number of grade 3, 4 adverse events and the number of serious adverse events are actually similar between the two arms. But there were more dose reductions and dose delays that occurred with TDXD and pertuzumab compared to THP. There are also more treatment-related deaths with TDXD and pertuzumab, with 5 deaths compared to 1 on the THP arm. Shown here are the most common adverse events that were seen by arm, and I think they're very consistent with what we already know to be toxicities from these agents, with nausea, diarrhea, neutropenia being very common with TDXD and pertuzumab, and diarrhea, neutropenia, and anemia being common with THP. Overall, the rate of interstitial lung disease was 12% with TDXD and pertuzumab, with the majority of ILD events being low grade, but there were 2 grade 5 events that did occur on the TDXD and pertuzumab arm. So overall, I think what the DESTINY-Breast09 study showed us was that giving TDXD and pertuzumab, in essence, is doubling progression-free survival compared to our current standard of care with THP. We're also seeing a higher response rate, higher complete response rate, and overall the safety profile, I think, was consistent with what we already know to be toxicities from the agents that were utilized. So this has, I think, the potential to become a new first-line standard of care. But Kevin, I'd love to get your thoughts on this. Obviously, this is a different approach than the way we currently treat our first-line metastatic HER2-positive patients, where I think we've become accustomed to the idea of using induction therapy with THP and then putting people onto HP maintenance. We've also seen things evolve recently with patina for our hormone receptor positive patients, adding endocrine therapy and CDK4/6 into the maintenance setting. So how do you think about this in our current perspective? Do you think TDXD and pertuzumab should be utilized? Should it be utilized in select patients? What are your thoughts?
Yeah, I mean, I think that it's nice to see that a drug that is so active in patients, and we've seen data, second line plus, that we see that sort of activity in the first line setting. And so, I think we're not surprised by the efficacy that we're seeing. And the side effect profile, as you mentioned, is similar to what we would have anticipated, and we're waiting for data of just TDXD alone. Ultimately, I think that there are a number of questions that remain, including what you had said about, we think about some sort of induction approach similar to what was done in Cleopatra, and then maybe taking off some therapies. And so one of the questions being, well, if you start with TDXD and pertuzumab, can you then, I don't want to use the word de-escalate, but then like bring up, perhaps take away the TDXD and continue HP, for instance. You mentioned patina. We should never be doing cross-trial comparisons, but we see for patients who have hormone receptor positive disease, we saw really nice median progression-free survival of giving endocrine therapy, HER2-targeted therapy, and palbociclib. And so I think, and I'm curious what you think as well, but I think that there's some patients I might continue TDXD and pertuzumab in if this is, available as an option to us, like those patients with significant visceral disease who still need a response, maybe patients with CNS metastasis. But I also think for other patients, I might start this and do this for 6 cycles or so. And then maybe if they're hormone receptor positive, do the patina regimen. And if they've had a great response and they're hormone receptor negative, maybe do just something like HP and see how they do. I'm curious what you think.
I wish I had all the answers because I think, right, that it does bring up so many questions. Here we only have data for patients really getting treated with the regimen until time of disease progression or stopping due to toxicity. But I think what you're referring to is we would really love to understand, could we get to a point where we get someone to a complete response or maximal response and then switch them over to maintenance, which was not done in Destiny Breast 09, really with the idea of trying to, preserve quality of life, put people on, maybe dual antibodies without any cytotoxic treatment to really maintain that tremendous response. And I think that's really an open question because we don't know, would we gain the same level of efficacy from that strategy as we have seen in Destiny Breast 09, where that wasn't the strategy that was taken. And so there are studies that are ongoing to look at that. For example, like Demether, which is a single arm study, but giving 6 cycles of TDXD followed by HP maintenance and allowing endocrine treatment to be added in that maintenance setting, though it doesn't allow CDK4/6 to be added. So I think it does raise all these questions. I think practically speaking, I think most of us are going to want to use TDXD and pertuzumab simply because of the more robust efficacy. But I think people are going to want to better understand, could we think about an approach where maybe we don't have to continue indefinitely until disease progression? And hopefully we'll learn more as these studies emerge. So it's to have the potential to do this. So
Totally agreed.
So next we'll turn to the triple negative setting where we saw data from ASCENT 04. This was a trial that was looking to understand if the combination of sacituzumab plus pembrolizumab could be better than the current standard of care chemotherapy plus pembrolizumab for patients who have previously untreated metastatic triple negative breast cancer that is PD-L1 positive. So certainly we have data from Keynote 355 that really established chemotherapy and pembrolizumab as the current first-line standard of care for patients with PD-L1 positive metastatic triple negative disease. But we've seen how effective sacituzumab govitecan can be in pretreated triple negative disease, where it looks so much better than chemotherapy. And we've also seen some really interesting data to suggest that ADCs could work synergistically with checkpoint inhibition. And so it made the idea of looking at the combination of sacituzumab and pembrolizumab in this setting very attractive. So ASCENT 04 took patients who had never had any systemic treatment for their metastatic triple negative breast cancer and had tumors that were centrally confirmed to be triple negative and PD-L1 positive, and randomized them to get sacituzumab plus pembrolizumab or chemotherapy plus pembrolizumab, with the primary endpoint being progression-free survival. For those patients on the chemotherapy arm in the trial, patients had to select which chemo drug they would choose if randomized to that arm before randomization. And so about half the patients elected to receive a taxane and half chose to receive gemcitabine plus carboplatin. Here are the primary endpoint data for progression-free survival, where you can see that the combination of sacituzumab and pembrolizumab led to a significant improvement in PFS compared to chemo plus pembro, with a median PFS of 11.2 months compared to 7.8 months. So I think, a very robust difference of about 3.4 months between the two arms. And you can see that benefit was really seen across all landmark time points, where at 12 months, you see 48% of patients were free of disease progression or death within the sacituzumab plus pembrolizumab arm, compared to 33% in the chemotherapy plus pembrolizumab arm. When looking at the subgroup analyses, you can really see that the benefit for sacituzumab and pembrolizumab was seen really across all key subgroups, with the exception of those patients who had received a prior checkpoint inhibitor in the early disease setting. Just be cautious when interpreting these data, because there are only 20 patients who had received a checkpoint inhibitor in the early disease setting. So it makes the confidence intervals very large, and I think very difficult to really draw any definitive conclusions from. The objective response rate was numerically higher with sacituzumab and pembrolizumab compared to chemo plus pembro. And the complete response rate was also numerically higher at 13% compared to 8% with chemo pembro. The overall survival data was very immature at this time point, but we did see a trend favoring sacituzumab and pembrolizumab with a hazard ratio of 0.89. I would note that in this trial, for patients who were randomized to the chemo plus pembro arm, they were provided sacituzumab at the time of centrally confirmed disease progression, and a little over 80% of patients went on to receive sacituzumab after discontinuing chemo pembro. So there was a very high crossover rate in this trial. When looking at the safety data, you can see that overall the number of grade 3-4 adverse events was similar between the two arms. There were numerically more serious adverse events with sacituzumab and pembrolizumab compared to chemotherapy plus pembrolizumab, but the rate of discontinuation due to adverse events was lower with sacituzumab and pembrolizumab compared to chemo pembro, with 12% of patients discontinuing sacituzumab pembro due to adverse events compared to about 30% of patients on the chemo pembro arm. Here are the adverse events of special interest. One thing that we were interested in understanding was, if you looked at high-grade diarrhea with sacituzumab and pembrolizumab, we were curious to know if it was different from what we're accustomed to seeing with sacituzumab alone. And you can see that the rate of grade 3 and higher diarrhea with sacituzumab and pembrolizumab was 10%, which is actually very much in line with what you see with sacituzumab alone, suggesting that we're not really seeing additive toxicities. And this was also true when looking at immune-related adverse events, that there was no increase in rate of immune-related adverse events with sacituzumab and pembrolizumab compared to chemo pembro. So overall, this study showed that sacituzumab and pembrolizumab led to a significant improvement in progression-free survival compared to chemo plus pembro, with about a 3.4-month absolute difference between the two arms and a hazard ratio of 0.65. The objective response rate was higher. The duration of response was more durable with sacituzumab and pembrolizumab, and survival data is still immature, but there's a slight trend favoring sacituzumab and pembrolizumab, despite seeing a very high crossover rate in this trial. So, overall, I think these data were very encouraging, and we're certainly waiting on an approval. Kevin, I know you're also very involved in this study, so I suppose we're both a bit biased. But I'm curious, do you think that this is a regimen that we should use across the board in patients who have, untreated first-line metastatic PD-L1 positive triple-negative disease?
I do. I think that this is really practice informing. We'll also talk about some data in just a moment, which I think were maybe controversial. We felt like we needed some additional time to make a determination to see whether it's practice informing. But these data I thought were compelling. I mean, as you were presenting it, I just again was struck by the landmark analyses, like that 12-month landmark analysis where like nearly 50% of patients, had not had an event. And, just because historically we've thought of TNBC of having a median survival of like around 12 months, right? And those are on frontline therapy. And of course, not everybody goes on to get second line therapy, but still, I find these data compelling. I also think it's a moment in time, right? Because we're going to see ADCs go into the residual disease setting. And so the question's going to be like, how's that all going to shift? But for now, it feels practice informing. What do you think?
Yeah, no, I agree. I think this is a tough disease. And so to see improvements is really critical in that upfront setting because we also know that a lot of patients don't make it on to second line therapy with how aggressive this cancer is. And so I think it's nice to have a potential new treatment for them. So, Kevin, I will pass it over to you to take us through Serena 6.
All right. So let's talk about Serena 6, which was discussed in the plenary session. So this was a study that was looking at patients who were receiving frontline aromatase inhibitor and a CDK4/6 inhibitor. So it could be any of the CDK4/6 inhibitors that we have currently approved. After 6 months, if patients had not had any radiographic progression, then they can start having ctDNA evaluations per the Garden assay. And if they had detection of an ESR1 mutation, at that point they had scans. And if they did not have any radiographic progression, they were randomly assigned. And this was a placebo-controlled trial. So patients were taking 3 pills, one of which was a placebo. And so they were randomly assigned to continue what they were taking, including their prior CDK4/6 inhibitor, or switch to continue that CDK4/6 inhibitor and were switched to the oral SERD camizestrant, which is not yet approved. And we saw data for progression-free survival, and we saw some initial data for PFS2, which is essentially, to make sure we're all on the same page, the time that patients were randomly assigned to their first progression and then through their second progression. And we'd seen some data from PADO1, which was a phase 2 trial that used fulvestrant. But again, this is a different SERD, and this was a larger study and included placebo. So I just want to highlight a few characteristics here. If you look at the bottom, you can see the time since start of their AI CDK4/6 inhibitor. And so the median was about 2 years from when they had started their initial AI CDK4/6 inhibitor. Okay. Also, if you look at the upper box, you can see the median time of detection of an ESR1 mutation was again about 2 years. In the majority of those patients, about half of those patients had an ESR1 mutation that was detected at that first test. And you can see the mutations that are listed here, the common hotspot mutations. The majority of these patients were receiving palbociclib with about 15% ribociclib and around 10% abemaciclib. These are the data for progression-free survival. And one can see that in the Cami arm, it was a median progression-free survival of 16 months. And in the AI arm, it was 9.2 months with a hazard ratio of 0.44 and a statistically significant p-value. These are the various subgroups, and one can see across all the different subgroups that there wasn't a group that seemed to not benefit from the switch to Cami. Importantly, we have some initial data of PFS2, and what's being shown here is 12-month PFS2. There is a trend towards an improvement, but these are data that are important for maturity as we see how patients did, not just once they were randomly assigned, but also how they did with subsequent treatment approaches. And then the other thing that was quite interesting, maybe open for discussion, is the fact that they had these global health scores that were evaluated through the ERTC QLQC30. And then ultimately, you saw that the patients who were continuing their AI had a worse global health status pretty quickly compared to those who were receiving Cami. These are the side effects that, in terms of those that were leading to discontinuation. Long story short, the rates were pretty similar between the two arms. And in terms of the actual toxicities, the rate of neutropenia was similar between the two groups, and that was really driven by the CDK4/6 inhibitor. One of the side effects of Cami that is worth mentioning is that we can see photopsia. Photopsia, Erica Hamilton, I think, describes quite well as you walk into a movie theater and your eyes take a moment to adjust. That's what's commonly described, and that is tended to be a low-grade event. And you can see just a smattering of other potential side effects as well. The majority, vast majority of those were low grade. And so in conclusion, the study did reach its primary endpoint. I do think that, this is a large randomized phase 3 trial. Angie DeMichel gave an excellent discussion about what we know and don't know from this study. One of the points that she had highlighted was just the need for continued follow-up and looking at PFS2, also overall survival will ultimately be reported as well, though the question is whether it's really powered to look at that endpoint. Right now, I would say that, this is not practice informing because we don't have Cami, and I would not think about doing this in the absence of Cami or utilizing this with elacestrant, for instance. But Sarah, I'm curious what your takeaways were from Serena-6 in the discussion.
Yeah. Well, one, I will say, I think this is just such a big paradigm shift in terms of the way we think about treating cancer, right? Because we always wait till someone has anatomic progression and then we switch drugs. But this is saying, can we actually detect molecular resistance and then switch before anatomic progression? And so this is it was a very innovative trial, I will say. I really do think this is exciting to think about. And, here what we're seeing is that progression-free survival is better, quality of life is better. But I think the question that we're all grappling with, and I'm still struggling with, is is this going to change someone's long-term outcomes? Is this going to change their survival if I switch at the time of that molecular resistance mechanism rather than just waiting until anatomic progression and then putting them on a SERD, for example, at that point in time? And, this trial, it makes it hard to really understand because, unfortunately, we're limited when trials are developed with investigational agents. You can't provide crossover. But I think if in a world where that could be done, I think that would have been what we would have wanted to understand is kind of this now versus later type of question, which we can't fully address in a trial without strict crossover. So I think that's why there's a lot of trouble understanding, should we just switch over and do this for everyone? Obviously it's super innovative and exciting. And I will say I enrolled a lot of patients onto Serena-6 and patients loved it. They loved the idea of being proactive, being able to switch at the time of seeing that resistance develop. And I think the quality of life data is actually quite provocative. I think we need to dig into it a little bit more, but it makes me wonder, patients often know when they're starting to progress, right? They feel it before the scan shows it. And as part of what we're seeing, some of that, patients are feeling better because they made that switch without letting their disease progress. And so if that really is true, this could be quite meaningful for patients to prevent all those symptoms from developing during the time of disease progression. And so I think we need to understand this a little more. It'll be great to see more mature PFS data. It'd be great to see more detailed QOL analysis. But I think it was a really exciting study.
Yeah. I think there are lots of considerations, including costs with, checking for ctDNA and how patients will respond to. I also had patients on and they liked it. And when we stopped doing it, they were like, well, why we stopped doing it? I just feel like, I think the take home really is just we need more data.
Yeah.
We need longer follow-up. Okay, I'm just going to briefly go through this study. We've seen these data before in terms of progression-free survival, but we saw some overall survival data and an update in PFS. So Novo 120 is the study that led to the approval of inavolisib in the frontline setting for patients with PI3K mutations. And so this is a very specific population. And so these are patients who had tumors that progressed within 12 months of completing their adjuvant endocrine therapy. So those patients who had early recurrences, and they were randomly assigned to placebo, fulvestrant, placebo versus the triplet of fulvestrant, palbociclib, and inavolisib, which is given at 9 milligrams by mouth daily. I also just want to highlight that there was a fasting glucose requirement, that it was less than 126 mg per DL, and they had to have a hemoglobin A1C that was less than 6%. So these are the data with updated progression-free survival, quite impressive, right? An almost 10-month improvement in progression-free survival now with a median follow-up of around 3 years. And this slope of the curve that you see in particular for the patients in the placebo arm, you can see how quickly they recur, how poorly these patients can have behavior of their tumors, but how well they seem to do with the addition of inavolisib. And then we also saw an improvement in overall survival, of a difference of about 7 months. This study did not allow crossover, which we've talked about, is different than the ASCENT data that Sara had presented, which was part of the discussion afterwards, was the lack of crossover in this particular study. So in terms of what patients received after, one can see in the inavolisib, so inavolisib is the middle columns, and one can see that after inavolisib, about 50% of patients received chemotherapy. Few had received an ADC, and about 6% had received a PI3K inhibitor. Compare that to the placebo arms, where you can see second line, about 3/4 of patients had received chemo. And again, very few patients ADCs, and very few patients had received a PI3K inhibitor afterwards. So if you had received placebo in this study, the vast majority had gone on, if they went on to get second line plus therapy, it was not a PI3K inhibitor. It was commonly chemo. Safety had been previously described. I really just want to highlight the side effects of adding in palbociclib. Those really, of adding in the inavolisib to the palbociclib, of course, we see side effects due to the CDK4/6 inhibitor, like issues with blood counts. But one of the things to really look out for with this regimen, beyond hyperglycemia, can be stomatitis. And so it's helpful to use the steroid rinse preventatively, and I've had that's anecdotal as well, to help prevent that stomatitis. So ultimately, we saw an improvement, not just in progression-free survival and overall survival. We have an indication for this study, for this drug already in this with this particular agent. So it's mentioning that this is the first time we've seen an overall survival improvement with a PI3K AKT pathway inhibitor. Sara, I've been feeling like Inavo 120 was practice informing already. I do think that, some of the criticisms have been highlighted already in terms of interpretation of the overall survival data, et cetera. But I feel like these data just further reinforce for this population that we would consider utilizing a triplet. I'm curious what you think.
Yeah, no, I will say, you're right. I think we've already changed practice before we saw the mature OS data, just because these data were striking. To see such a large difference, more than doubling of progression-free survival is a big deal. These are patients who recurred on or within a year of endocrine treatment. So they're patients who, are endocrine refractory and have a PI3K mutation. And so you see the control arm doesn't do very well. And you're seeing this tremendous benefit from adding the PI3K inhibitor. So, I think it is a really important strategy that we do need to screen our patients in the first line setting to know if they have a PI3K mutation up front. One of the limitations, though, is that this was done at a time where patients hadn't seen an adjuvant CDK4/6 inhibitor. And so in the current era, as we may start seeing patients recur after adjuvant CDK, it is going to raise the question, how would this actually work in someone who's seen a CDK4/6 inhibitor before? And we just don't have data on that at this time. And so that does remain an open question.
Yeah, for sure. And I also think, just like forward thinking, now we are increasingly evaluating PI3K mutation specific inhibitors. Like, the field is just evolving in terms of the agents that we have. But again, this study is for a very specific population. Those are patients who have early recurrences on their adjuvant endocrine therapy.
Thank you, Dr. Kalinsky and Dr. Tolaney, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, CCO Independent Conference highlights from the 2025 ASCO Annual Meeting, Please click the link in the show notes and be sure to check back regularly for more episodes on important clinical care options oncology podcast topics.